You, ma'am, and thank you for AIS for allowing me to speak on this topic. So as we have been discussing since morning about the treatment of glaucoma, and we know very well that glaucoma is a slowly progressive disease, and if not treated correctly is going to probably lead to blindness. So there are studies to show the incidence of blindness in glaucoma patients, and I'm going to skip this quite fast. But most important is who are the patients who are going to go or go into blindness or severe vision problems. So the studies have shown that patients who have got higher age, means advancing age per year, is one risk factor. Stage of the disease is the second risk factor. So obviously more advanced disease, more likely to progress to blindness. And the most important is the IOP, which is the factor which we are quite a lot seeing and giving importance to. So at diagnosis, higher the pressure, the higher the chance of getting to blindness during the course of the disease. This is something which we need to keep in mind right at the beginning when we see the patient and we decide to treat the patient. The European Glaucoma Society treatment guidelines, as well as many other society treatment guidelines, all have aimed that the glaucoma treatment should be aimed to maintain the patient's visual function and quality of life at a sustainable cost during the patient's lifetime. As the disease progresses, the amount of limitations patient faces due to visual disability keep on increasing, as you can see here. And our aim is to stop the patient from going into that zone, which is the severe visual disability zone, during his lifetime period. And for practical purposes, we have to assume that patients' life expectancy in today's India is around 80 to 85 years, and we have to stop them from going there. So we have to identify which patients need to be treated first of all, and then decide how much they need to be treated. Some discussion was already held on the ocular hypertension and OCT by Dr. Devan. But the most important is the OHTS study has shown that, it was a study which was done for the patients with ocular hypertension and followed up for 5 years. And it showed that the probability of developing glaucoma was 4.4% in patients who were treated and 9.5% in patients who were observed. Based on these studies, risk factors were identified, and today's recommendation is that patients with ocular hypertension need to be treated if they have risk factors. So moderate and high risk factors should be offered treatment, but without risk factors, ocular hypertension, usually we are not advising treatment right at the beginning. So this is the basic idea. Important factor is how does the visual field decline going towards blindness. So we know that the normal visual field decline with age is around 0.06 decibels a year. In untreated glaucoma, it comes to around 1.1 decibels a year. This is open angle glaucoma. So if you can assume that a patient who has started with glaucoma is going to take about 20 years or 25 years to reach totally washed out fields. Clinical glaucoma, which we are treating, we are observing progression rates of 0.4 and 0.6. These are even well-treated patients. As the discussion was going on earlier, that even treated patients, well-treated patients, well-controlled patients do show progression. So it is not that we can completely eliminate progression or bring the progression rate to the level of the normal visual decline. And the best treatment, you are going to get 10 times faster decline than normal. So this is one big statistic that you need to keep in mind. Therefore, if this line is showing the age-related decline, and this is the glaucoma patients of different intensities showing the rate of decline is different. So as you can see that these patients who have a slow decline are not going to lead to severe visual function impairment during their lifetime. Whereas a patient who has a little faster decline but has started glaucoma later also is not going to land up there. The idea is to control these patients who are having glaucoma at a younger age and progressing very rapidly to go into the zone where you don't want them to go. And your business is to identify these patients in time and treat them appropriately and aggressively so that we can stop them from going into the zone of severe visual function restriction. Now there is a relationship between the IOP and the progression, and numerous studies have shown that intraocular pressure reduction is definitely associated with the risk of reduction in the risk of progression. And based on this, all the societies and all the glaucoma specialists agree on this point, is that when you start treatment, you have to identify what is the intensity with which you need to treat this patient. And the three important factors you're going to keep in mind is the amount of glaucoma damage you have identified at the time of treatment initiation. How long is the patient going to live, expected to live, life expectancy? And what was the intraocular pressure in the untreated status when you first picked up the patient? Besides that, you have to identify some additional risk factors, which we are going to come to slowly. But the very important factor, rate of progression. Now, in the initial part, when you are going to start treatment, this data is definitely not going to be available to you. So you have to start treatment based on these data and keep a weightage simple, that if the patient has early damage, then you are going to allow the pressure to be a little higher, your targeted pressure, as opposed to a patient with more advanced damage, you would want further lower target pressure. Same way, the longer the patient's life expectancy, you would like to keep the target pressure lower. And the untreated pressure, example I will say, supposing you diagnosed a patient with the intraocular pressure of 25 as the highest pressure, as opposed to another patient in which you diagnosed him at 40 or 45. So if the initial pressure is lower, then your target pressure is going to be lower. And if you are higher, and if your untreated pressure is higher, then you are going to opt for a further reduction in target pressure. Additional risk factors we are going to come to. What are we going to keep in mind? So there are other risk factors you have to keep in mind, is the corneal thickness, the family history. Gonioscopy, of course, is very important, because these discussion on target pressure is totally not applicable as long as you have a patient who has an appositional or a cynical angle closure, which you haven't yet done an iridotomy on. So only and only after you have done the iridotomy and established some reopening of the angle can you start applying these rules of target pressure. When you take the intraocular pressure, you have to keep the diurnal fluctuations in mind. So it is a good idea to try to observe the patient during the day and see what range the patient is fluctuating. Pseudo exfoliation and pigment dispersion are additional risk factors, and if you see them to be present in the case, you have to target for lower target pressures. Presence of other systemic diseases definitely plays a role, and in that, cardiac diseases and respiratory diseases are extremely important to be kept in mind. Now, as was mentioned by Dr. Tully, is that when you are started treatment and you are going to evaluate and try to identify the patients who are going to progress more rapidly as compared to others, what are you going to use? You are going to use standard white on white automated perimetry. OCT has not been validated for this purpose, and therefore you have to be doing perimetry tests at least 3 times a year. So say roughly at least about every 4 months. And in the first 2 years, you need to get about 6 or maybe 8 tests done to be having enough data to be able to detect a 4 decibel change in the deviation over the first 2 years. So the first 2 years, as I always inform my patients, are a probation period when you start your treatment on glaucoma, because your individualized target pressure which you have set is only a guideline and it is not final, because you have to identify whether it is able to control progression to a satisfactory level or not. So when you have a target pressure which you have identified based on a percentage of the absolute pressure or a predetermined IOP, and you must have something guiding on both. The IOP lowering definitely depends on the baseline pressure. So you are going to aim minimum 25% some reduction and to inhibit progression. And you have to have a range. So you have to put a range something like 15 to 18 kind of, this is just an example, to be able to have patients who are controlled, and this is the pressure at which many of the patients don't progress. But you have to have it individualized at diagnosis, and during the course of the disease, as you follow up the patient with perimetry, you need to know and go on changing the target pressures depending on what the data shows you. So you have this same graph which I showed you earlier. Glaucoma, early disease, you can have a pressure around in the high teens or mid teens, as opposed to advanced disease where you go for low teens. Life expectancy, older patient who has a shorter life expectancy, again you can accept something like mid-teens, but a younger patient who has a longer life expectancy, you will be going down to lower teens. And also the untreated pressure, so a patient who has had a pressure, say, as I mentioned, a patient who has had a pressure in around 45-50 and you are going to treat, obviously you are going to have 25-50% reduction also, it is going to come in mid-teens, as opposed to a patient who has got a pressure of 25 and you are going to reduce it by 40%, you are going to come down to low teens, and sometimes you need to come down to a single digit. Additional risk factors which I mentioned, like pseudo exfoliation and pigment dispersion and hemorrhage of the optic disc or a thin cornea, if they are present, you have to go further down. So even if the glaucoma is early damage and you are accepting mid-teens, presence of additional risk factors will make you go further down on this graph. And if they are not, then you discount this and only follow what is here. As you follow up the patient and you see the progression rate, that is after you have had 6 or 8 perimetry tests and you have had a linear progression graph based on the event base as well as the trend based analysis, and you see that the progression is slow, then even if you have set a lower pressure, you can allow the pressure to be a little higher. But the opposite, if you identify a fast progressor, you have to modify your target pressure to a lower level immediately, because this means that your treatment, what you determined earlier, is not sufficient. Once you decide to treat the patient, then you have to identify which is the patient who, which drug are you going to give the patient. So first is, this is the rough idea. Early glaucoma, you're going to aim for less than 18. Moderate glaucoma, you're going to aim for less than 15. Advanced glaucoma, less than 12. And very terminal glaucoma, something like what Manish Singh showed his first case, will be going to less than 10. And that's what he was maintaining in his case. In NTG, if it is early glaucoma, less than 15 usually. Moderate glaucoma, you have to go less than 12. And advanced glaucoma, it will have to be again less than 10 or in single digits. So when you start identifying which drug are you going to use as your first drug, so this is the drug of first choice or the treatment of first choice. And the first line treatment today usually is either a prostaglandin or a beta blocker. And prostaglandins are generally preferred. Why is that? Because the first factor you have to consider is safety. You need systemic and ocular safety, which is the highest with prostaglandins as compared to beta blockers. The second factor is, what is the mechanism of action and how much pressure reduction is it going to give you? Definitely prostaglandins are the drugs which are able to give you the maximum pressure reduction with a single drop. So efficacy is maximum, and they are outflow drugs. Generally, we prefer outflow drugs as the first choice, because when you use an outflow drug, you are going to get lesser diurnal fluctuations as opposed to an inflow drug reduction, which is more prone for diurnal fluctuations. And quite a few studies do show that diurnal fluctuations also play an important role in progression. And the simple compliance of just one drop is very, very important, since even Manish Singh mentioned problem is compliance, and we are not probably estimating how big a problem it is. So when you start treatment, the basic guideline is a single medication is far more preferable than using multiple, because you are decreasing the risk of side effects, and patient compliance may be significantly better. So when you want to start treatment and you are able to achieve your target pressure with a prostaglandin, you would definitely prefer a prostaglandin over any other drug. So, but there are many prostaglandins available. Which one are you going to choose? Are you going to play a knick-knack no and just pick up any one, or is there some science behind it? So when, and most important you need to remember is, when response of one is not enough, because many times you start a drug, then you have to observe whether it is giving you the target pressure desired or not. And you find that whatever you gave was not good enough, it is worth trying another from the same group, because there is enough evidence to show us that a non-responder with one prostaglandin can respond very well to another. And it is very worthwhile for us to understand that all the prostaglandin IOP reduction studies which have been done have shown more or less similar efficacy. It is not that any one prostaglandin IOP reduction is a lot better, but in general, it is that the bimatoprost in 0.03 ml per liter is definitely likely to give you a little more as compared to travoprost, and latanoprost seems to be a little less. But the difference between these graphs is very minuscule, and in real life, how much it makes a difference, you cannot really say. This is a study by Lee et al. Published in 2016, and he has put, this is a kind of a power list which shows that IOP reducing effect based on overview of 114 randomized control trials, and they have identified that bimatoprost is 5.6, latanoprost is 4.8, travoprost is 4.83, and that way it keeps showing as from the strongest IOP reducing potency to the least IOP reducing potency. All the commonly used glaucoma drops are shown here. So based on this, you are going to be able to select what is safe and effective in your patient. And in usual scenario, we do select prostaglandins, any one of the four, as our initial treatment. But prostaglandins come with their problem. Number one problem is the red eye. Number two problem is some amount of local irritation, skin pigmentation, and lash growth. And these problems are quite common, and I would say a very high percentage of patients in whom you start will have these complaints. And of course, as time goes, the eye adapts and the red eye and the irritation does become less. But the pigmentation of the skin and lash growth are permanent, and they do cause cosmetic issues, especially in patients in whom you are going to use it only in one eye. The cost is definitely also a factor which you have to keep in mind. The dry eye is increasingly being reported, and some of it is because of the preservative, but I would also like to stress that some of it is not only preservative, but also because of the drug itself. Other issues which are often discussed as problems with prostaglandins are the incidence of cystoid macular edema, reactivation of uveitis, and herpes simplex keratitis. I would say that in a majority of cases, these factors don't play a role, and they only play a role in very small, minuscule number of cases, and they are not an issue generally when we are treating open angle glaucoma. Beta blockers, coming the second choice drugs, are definitely one of the best tolerated. And the point is that as a monotherapy, they are useful only in a small percentage of patients who are ocular hypertensives with very, very early damage, or maybe just very early POAG, because only in those patients will you be able to accept the pressure which you will get with a monotherapy of beta blockers. Also, systemic contraindications to beta blockers over the last 20 years that I have been in practice seem to be increasing. Quite a big number of increases there. There is a problem of tachyphylaxis where over time the effectivity of beta blockers reduces. Usually it is a period of 2 years. Dr. Manish Singh also mentioned about the effect of reducing ocular blood flow, especially at the optic nerve. The second problem is that the night lab studies have shown that effectivity of beta blockers during the night time are almost zero. So they are not drugs which work during the night, though all the other drugs also which work much less than they do in the daytime. The alpha-2 agonists have IOP reducing effects similar to beta blockers, and they are very useful as adjunctive therapy, as Dr. Manish Singh pointed out in his talk. And most important is that there is no effect on the blood flow as we have seen with beta blockers. Neuroprotection effect he did mention in his talk, and as he has put a question mark, so have I. You have to remember that in children less than 2, it is definitely contraindicated. Even in less than 5, I would be very careful to use. And allergies, even allergies after the use of some period of time, are a big problem, and that is the number one reason alpha agonists need to be discontinued. So coming to the strategy when you have first started the treatment is that you are going to detect patients who have visual field progressions early, and to prevent further loss, treat them more aggressively. And those who are not progressing, you can leave them treated in the way that you have been treating. And as far as progression is concerned, in the EMGT, 14% of patients in the first 2 years showed progression. And in the United Kingdom glaucoma treatment trial, in the first 2 years, 15% of treated patients showed progression. So you can see that a good number of patients will show progression, and you will need to identify them and treat them. So what is your algorithm? Algorithm, as I said, is that when you have individualized target pressure and you are going to treat, then you are going to look for progression. If you get progression, you have to lower your target pressure. If it is stable, you continue to observe with repeat visual fields. After the first 2 years in stable patients, you can increase the interval to 6 months. Still, you may get progression little late also, and then also the same concept, consider lower target. But if it remains stable, you can consider to do what you are continuously doing. Follow-up intervals in patients who show progression still remain 3-4 months repeat perimetry, because you have not yet still established them to be having a good stable progression rate. So if you have started adding drugs and the target pressure is not reached because you have now lowered your target pressure, you will need to add drugs. And if you add a second drug and you get your target pressure, then again it goes back to the state where you are going to continuously observe. But as I said earlier, once you see progression, you are not going to reduce your interval of tests. If target pressure is not reached by a second drug, you may have to substitute the second drug with another one or add a third drug. But this is a good time to consider surgery or laser treatment or some other non-medical intervention, because you know that there is a problem with multiple drug therapy. One point I would like to make very specifically is that moment you add a second drug, you must know that it should give you additional pressure reduction of around 15%. And therefore, be smart in adding the second drug by considering the variables, that is the complementary mechanism of action. If you have a drug which is working as an outflow drug, you can add the second drug, which is an inflow drug. And keep in mind neuroprotection and vasoprotection, as Dr. Manish Singh mentioned. But again, your safety and tolerability issues are the main focus. So medical medications increase, more medications increase effects, side effects are there, and it is important to select the agent with a favorable safety profile. And also, as I mentioned, select outflow drug with an inflow drug, and that way you can combine beta blocker with a prostaglandin or a brimonidine with a prostaglandin, because they work very well in different mechanisms and it will give you the maximum beneficial effect. The topical carbonic anhydrase group
Can
of
you
drugs
sum up,
are rarely used
Dr.
as
Manish? Yeah.
a single line of treatment. It is usually used as an add-on therapy, and it is a good additional therapy to beta blockers as well as prostaglandin analogs. But keep in mind that if you're already using oral carbonic anhydrase inhibitors, it is not going to be as effective. And in corneal endothelial and allergies problems, you are going to have contraindications of using these group of drugs. Pilocarpine is an orphan drug. Nobody talks about it, but you have to remember it is a very effective drug. Not very popular due to tolerability issues, better tolerability with timolol fixed drug combination. And it is useful in pseudophakic eyes as well as patients with residual angle closure after the PI has been done, but not a good idea in young patients and myopes. Also, you have the new group of drugs called the ROCK2 inhibitors. That is a drug which works on the Rho kinase receptors. They work by increasing the uveoscleral outflow. The unique advantage of this group of drugs is that it is effective in low corneal endothelial count patients, and in uveitis patients it is beneficial because it suppresses some amount of uveitis. Two drugs which fall in this category are netasudil and ripasudil, out of which now ripasudil is available to us in the Indian market. So coming back to when we want to add drugs, the first, as I mentioned, you have given a prostaglandin in one bottle. Now you want to add the second drug, you can still keep it a single bottle by giving a fixed drug combination with a beta blocker. Or you have the option of adding the second bottle if this is not enough. The second bottle, as Dr. Manish Singh mentioned, would be an alpha agonist or a carbonic anhydrase inhibitor. And the third bottle that is coming to a maximal medical therapy is the other one which you have not given in the second, you have to give in the third, or you can use ripasudil. But pretty much 3 drops is a maximum. Even 2 bottles actually I think is maximum. With these new concepts, you will have to give low target pressures to a good number of your patients and achieve very stable diurnal control. And therefore many drugs and many patients will have more than one drug. So keeping in mind that the compliance is going to be a problem. Moment you add the second drop, your compliance rate is going to drop to 1/3. So you have to keep this in mind, Therefore, it's a good idea to use the drug combination in one bottle, 2 drugs, because they are easy. You'll get better compliance, better quality of life, fewer preservative side effects, and interval between drops. That means if you are giving 2 drops and the patient puts one after the other without an interval, he's going to wash off the first drop with the second drop. In the fixed drug combination, that is not going to happen. So you'll get better effectivity.
Dr. Manish, can you please conclude?
It is my topic is very long, and I had mentioned this to the organizers
Yeah,
right in the
yeah,
beginning. So I
because
would,
we have a speaker
and
after the
if
discussion.
I can go a little bit faster.
Yeah, just go
And
a little bit faster because some things have been covered up by Dr. Singh and Dr. Tuli. So, yeah.
so as I mentioned, beta blockers contraindications are a problem, and increasing number of patients show constriction, contraindication due to airway disease, cardiac arrhythmia, and they start, even patients who didn't have anything, many times after starting a beta blocker, they start developing bradycardia and hypotension. This is a matter of concern, and I would like to point this out because very often we take the history of these two and we start the drug, but after starting the drug, when this develops, we are completely unaware, and it might be a shock. As I mentioned, tachyphylaxis is also a problem, and up to 40% it is contraindicated. So if a beta blocker is contraindicated, what will you use? So then you are forced to use 2 bottles. You will have to use the alpha agonist or a carbonic anhydrase as a second bottle with the prostaglandin. And if that is not, you can also use a fixed drug combination of brimonidine and brinzolamide, which is available today, as the second bottle. So you will get 3 drugs in 2 bottles, or you can add ripasudil as the second bottle. But if you maximal medical therapy issue, the third bottle, usually I am preferring to use ripasudil in patients in whom beta blockers are contraindicated. The medical therapy failure is usually because of side effects and tolerability. Adherence and persistence also is a problem, and therefore most important is patients' awareness and understanding in what is being done for them. No time to go into details, so I am not going in. Usually in maximal medical therapy, you have to restrict to 2 bottles, which could have 3 drugs or 4 drugs, and keep a very good view on the tolerability and persistence of the thing. So in conclusion, in the beginning, identify the patients who need to be treated, identify the target pressure based on risk factors as well as the initial stage of the disease. Once you have done that, you can start with the monotherapy of prostaglandins usually, and have a very close observation with repeat visual fields every 4 months or so. Identify patients who are rapid progressors, which would be around for 15 to 20% of the patients, and treat them more aggressively with multi-drug therapy. And patients who are not progressing that rapidly, you can reduce the interval of repeat testing and keep them maintained well. Those patients who are showing progressions and intolerance to drugs, it may be a good idea to take up for lasers, that is SLT or surgery, and keep the minimum to medical therapy. Thank you very much.
Thank you very much.